Welcome to the Idaho Main Street Podcast, where we talk about the issues that matter to you.
Welcome back to the podcast. This year we're already rolling into 2025, and as we look at having episodes that matter and talking more about things that matter, we've looked back on previous seasons. Last season we had an episode where we talked to an IVF doctor, and the response to that was actually quite humbling. Not just from people who had struggled with infertility that were happy and proud to see that story have some light on it, but more importantly, people like myself who could barely spell IVF, who came out of that episode wiser to the issue and understood kind of the challenges that come with bringing healthcare and policy together in the same sentence. So we're going to try to do the same thing today with an issue that matters. So we talk about healthcare in Idaho, women's healthcare and nonviable pregnancies. And we've got two exceptional guests that not only bring immense experience, but a really compelling story. So we've got Dr. Pamela Denson here with us today, an OBGYN here in town. Met your husband at medical school, and you've both decided to be here and practice?
Well, I'm originally from Florida, and he was from Arkansas. And anyways, we met in Texas. We did our residency training there. And that's where we met and got married and everything. And then my in-laws bought a place out in Drake's, and we were coming out here, during the summer just to, enjoy everything and ski during the winter. And that's when we decided we wanted to work out here. And he loved the outdoors. And it was a little cold those first couple winters. But so we've been in the community practicing OB/GYN at both hospitals, Aramac and Mountain View, now for 10 years. So we have our own private practice. We're in practice together, which I know is a little unique, but it works pretty well for us. So
You don't get sick of working with your husband? No comment.
Well, we have a beautiful 8-year-old son, no, it's super fun actually working together. I mean, we did our training together, and we both complement each other really well. He really likes gynecology surgery stuff, and I really like obstetrics, and so I feel like we're a good combination. So
Love that.
yeah.
So you'll have to tell us a little bit about, you're on the front lines when it comes to this issue, when we talk about women's health care, when we talk
Right.
about these type of trigger laws in Idaho. Kind of frame this for us of why this
Absolutely.
matters in your unique position.
So, I've been in the community for 10 years, and I'll preface this by saying, I'm very conservative. I've never performed any elective abortions or anything of that sort. And actually, there's no OBGYNs in eastern Idaho that have ever performed elective abortions. And I think a lot of people don't realize that. But prior to this, if you wanted something like that, you did either have to go, I believe, Twin Falls, Boise, or you'd have to go to Salt Lake or Oregon. But the difference was if we had patients who we knew their babies were not going to survive after birth, like, for example, they had no kidney function, or they had a heart abnormality that was so deformed that no cardiothoracic surgeon could fix it, or some babies, unfortunately, are born with that missing skull and brain. You can't live with that after birth. And, a lot of people don't realize this, but in utero, so when your baby is in your uterus, mom is doing everything. She is providing all nutrition, all oxygen. That baby only has to grow. When it first comes out, it has to figure out how to open up its lungs and breathe, okay? And it has to figure out how to eat. So a lot of things that can survive in the uterus can't necessarily survive after delivery. And so, big malformations like that, no kidney function, the heart doesn't work, or no lung function, there's not a whole lot that medical or surgical intervention can do if you don't have any lung function. If you have a little bit of lung function, we have a lot of technology to help you out. But if you have no lung function or no kidney function, there's really nothing we can do.
And you can tell kind of if there's going to be some or none?
Absolutely. There's a lot of things that we can tell just on ultrasound, and there's a lot we can't. But if your baby's missing most of its brain, we can tell that on ultrasound. If your baby has such an incredible heart abnormality and we know nobody can fix it, most of the time we can tell on ultrasound. So there's quite a long list of different kind of conditions that we know early on. Most moms are usually diagnosed with that at the 20-week mark. So midway through their pregnancy, they'll get their complete anatomy ultrasound, and that's when we notice a lot of these major abnormalities. And, modern medicine is amazing. I've had patients whose intestines were completely hanging out of their abdomen. In utero, we can tell, and that can be fixed. We have pediatric surgeons here in Idaho Falls that can fix that. Now, don't get me wrong, it's quite a few surgeries, but these kids, after, it's been repaired, I mean, they're totally normal kiddos. They've been through a couple surgeries. So lots of things can be fixed, but some things can't be fixed. And we can't always 100% tell in utero. There's some things that, we have to wait till after delivery, but there are quite a few things that we can tell very early on that, hey, this baby just, it's lacking a bladder and a rectum. I mean, it's lacking so many things that there's no way this baby can survive once it's out of the womb. So what happened was, prior to the Dobbs decision, where the Supreme Court gave, the states the right to decide what they wanted to do with the abortion law, nobody in East Idaho did any elective abortions. But if we knew that a baby wasn't going to survive after delivery, a lot of times we gave mom the option, hey, do you want to deliver a little earlier? After it was diagnosed, because delivering earlier really decreases all the risks associated with pregnancy. It decreases postpartum hemorrhage. It decreases infection. It decreases your C-section rate. And so, and again, we're just delivering early is all we're really doing, just to kind of decrease those risks, because at the end of the day, that baby's not going to survive after delivery.
So you're inducing pregnancy, and the choice that the mother has is...
Exactly. So we're giving mom options. And I had patients that just, we would go over that with them, and we'd be like, hey, this baby's not going to survive. And they're like, I don't want any intervention until I'm ready to deliver. Some of my patients would say that. And so we, just whatever was easiest and best for them. And, after they've been counseled about all the risks, it's their decision. And some of them would be like, hey, I don't want to take all these additional risks. I've got a couple kiddos at home. I don't want to increase my risk of a C-section that could affect a future pregnancy. I don't want to have more, infection and bleeding and all this other. I would like to go ahead and deliver a little bit earlier. So prior to the Dobbs decision, we could go ahead and induce them sooner. And but anyways, once that was passed and the abortion law was changed in Idaho, then we are no longer allowed to deliver earlier for these unfortunate circumstances where we know that the baby's not going to survive after delivery. And there's another unique circumstance too. A lot of people don't realize this, but, if your water breaks before what we consider viability. So our NICUs are amazing. Our neonatologists, they do an amazing job. They can take these 22-week babies, which is, they're barely half cooked. You know what I mean? If you want to think of it that way. I mean, these are 1-pound babies. They are so small, but they can do miraculous things with them at 22 weeks. But if your water breaks, say, at 16 weeks, what a lot of people don't realize, and this all sounds kind of strange, but amniotic fluid is baby urine. Okay, so all that fluid that surrounds the baby is actually baby urine. The babies have to swallow amniotic fluid to get their lungs to develop. So if your water breaks before you can survive outside of the womb successfully, which is that 22-week mark for our NICUs here in Idaho Falls, and that's pretty standard around the country. If you have a level 3 NICU, they should be able to manage that. Then there is no lung function. So these babies won't, there's no chance that they're going to be able to breathe properly. And that whenever that sac ruptures, then, the entire uterus is exposed to all of the bacteria in the vagina. So they have a very high risk of infection. And in these scenarios, knowing that the baby's not going to survive and your high risk of infection and sepsis and death, we were able to counsel these patients that, hey, you have two options here. You can continue your pregnancy and know that these are your risks and know that your baby's most likely not going to survive, or you can induce early to decrease this risk of infection, sepsis, and death. And so now we're no longer able to do that either. So unfortunately, in both of these circumstances, the moms who we know their babies aren't going to survive, or their membranes ruptured so early that these babies are never going to develop any lung function, we're having to send all these people down to Salt Lake because they don't have any options here. So if they want to induce early because they know that their babies are going to have no lung function, and they have a very, very high risk of infection. We have to send them down to Salt Lake to be managed. And, that's a huge thing. Like, you work here, you have your other little kiddos here, they're 2, 3 years old, and your support structure's here, your family's here, and you're having to go all the way down to Salt Lake. And I think Kylie's going to tell us a little bit more about this, but, it's terrible. And sometimes your insurance doesn't cover it. I had one patient who decided her baby had no kidney function, and she decided she wanted to go to Salt Lake, and then her insurance declined it. So, I mean, these are terrible, terrible circumstances, you're already dealing with knowing that the baby that you're carrying is never going to be able to take, is never going to be able to breathe or function or do, isn't going to live very long after delivery, probably for a couple minutes at that, And these are sad, sad scenarios that you have to go through all this away from the doctor. And, all the people that support you are here to provide you with all that support, and you have to go all the way down there by yourself without that support structure. So
It's a perfect segue into Kylie's story here. So Kylie, not only incredible mom, leader in the community, principal of a local elementary school, and also a strong advocate. You could teach us all a thing or two about school facilities, what we need to update and work on. And there's a whole episode where you and I need to talk about that. But, a patient of Dr. Denson's over here. Why don't you walk us through, you experienced this on the other end so we have the healthcare provider and then we have the patient side. Tell us a little bit about what your experience was like.
Yeah, absolutely. I feel like I've had just kind of an intense journey having children in general, and Pam's been here pretty much through all of it. She delivered my first son, who's 8, and then after my son was born, when he was 3, my husband passed away. And so after he passed away, a few years went by, and I was like, I have a really heavy job, so I'm busy all the time, but I was like, I know that I want to have another baby, and I want my oldest to have a sibling, and so we jumped back in, and we had to do fertility stuff to have kids in general. So we went through one of the IVF places here, which was really great. And thankfully we had some embryos saved and stuff. So that worked out really well. But anyways, we got pregnant, went to Pam. Everything was pretty good. And then once we got to that 20-week appointment, I went in for the ultrasound, and that's when it's that one's supposed to be really fun. You find out the gender and all of that. And it was just silent. And so you just know something wasn't right, and the lady that was doing the ultrasound, she was like, I just need to get my boss or whoever was in charge. And at that point, I just knew that something wasn't right. And so they came back in. They said that things just looked not great. And then they called Pam over, which ironically is in the same building. And so she jumped over. And that was I ended up having her at 26 weeks. So there was about 6 weeks. There was about 6 weeks from the moment we knew that something wasn't right until I was able to actually do something about it. That we were kind of working through all the logistical things of what exactly is going on with the baby. If what we think is actually happening is happening, what do I do? Where do I go? How do I handle it? And so I worked with Dr. Pam. I worked with a fetal maternal doctor here in town. I think they're still here. And then ultimately went down to Salt Lake because we knew that it wasn't viable. And so I was pregnant with a little girl, ended up naming her Poppy. And she had what's called cloacal dysgenesis, and from what I understand. And so I learned a lot. I went down to Primary Children's in Salt Lake and ended up doing an MRI, I think is when they could tell exactly I had to have, for me to make a decision, I had to know for sure what it was. I couldn't make a decision like that without knowing exactly what was going on, And so went down there, and within half an hour they were not compatible with life, cannot survive, probably won't survive birth. And that made the decision easy for me. I shouldn't say easy, easier. But the scariest part, I think, is kind of what Dr. Pam was talking about, when they tell you all the things that could happen if you decide to keep carrying the baby. So you can kind of explain, I think, probably better what exactly her like malformation kind of thing was.
I mean, basically, there was no functioning bladder, kidneys, rectum. So again, your kidneys produce the amniotic fluid. And so then there's no lung function either. So, all of those things in combination is just not compatible with life. So
she was taking in all of the amniotic fluid, but she couldn't release it back out. So like she was growing, like measurements, everything was right. Like her body was growing, but it was just filling with amniotic fluid. And so they still offered, to carry her until she passed. They were pretty open with like, you're not going to make it to 40 weeks, But then the risks that came along with carrying her were what you were explaining.
Yeah.
Yeah.
And delivering at 20 something weeks in this scenario versus delivering at full term, very, 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 very different, because you have a much larger baby that has to pass through the birth canal. And a lot of times those babies, especially in this scenario where the urine wasn't passing, it was completely filled up in the abdomen. There's no way to have a vaginal delivery like that. So now it's an automatic C-section versus being able to be induced a little bit earlier and delivering normally, especially knowing that this baby just had no chance of survival whatsoever. And, in certain rare circumstances, there's even something called mirror syndrome where we have babies with heart failure in utero. So, they, for whatever reason, their hearts, and there's nothing we can do about these scenarios. But the mom, it's called mirror syndrome because the mom will actually develop heart failure.
Really?
Yeah. And that'll usually happen in the third trimester. So to decrease the risks of all these things happening, your infection, your bleeding, your necessity for a C-section because these babies are so abnormal that they can't fit through the birth canal at this point, they're really... we should have allowances for these scenarios to deliver a little bit sooner.
And that's similar to so once I went down there, that's exactly what happened is they were going to have to do a C-section, but they ended up doing a procedure beforehand where they went through my stomach into the baby and pulled all that amniotic fluid out of her so that I could have a natural birth. But I feel like the experience of having to just, this sounds really insensitive, but the logistical experience that goes along with it. It's like when someone that you love dies and you want to grieve, but you have to plan.
Sure.
That's exactly what it felt like. It felt like that there was so much on my to-do list and checklist in order to just get through it that it was just really bad. It was horrible. And so we went down there. Yeah, we had, my parents came up, thank goodness, they live in Boise. So they came and were with my son, and then my mom went down with me. But then even once you're down there, you don't have your same doctor, you don't have your same nurse, you don't know anybody. And so you kind of just jump into their rotation, and they they did great. I gave birth at U of U. They were wonderful, but you can tell they're not planning on you necessarily being there. Again, you don't know anybody, so you just feel like you're kind of floating through people. You get a room, and then, but before I could even get to the hospital, we were there for one night, and they're like, "Yeah, we think we can get you in tomorrow to do it." And we're like, "Okay." So you're sitting in a hotel room, and you know that your baby's not going to survive. You know you're having to give birth the next day, and all the while, baby's still alive. You can still feel her moving, and then the next day comes, you don't get the call. So then we have to go downstairs, get another hotel room. And then it's just this slow waiting game of sure would love to just be in my house, not here, So
It's almost like it takes your worst nightmares as a mom and just makes it worse.
it just stretches them out.
Yeah.
It just felt like everything was just it was just already a really long 6 weeks trying to figure out what was going on with her and what it was. And then once you make that heartbreaking decision of what you're going to do, then it's okay, now we're going to make it last longer, and we're going to make it go slow, surrounded by people you don't know.
What I've heard from mothers who talk about, the best part or most important part of childbirth was having their OBGYN there, having people they recognize who've been through their whole birth journey. As a provider, how frustrating is it to have to let it go?
It really is, because, these are the most sensitive situations that there are. I love delivering babies and be like, "Hey, congratulations, here's your baby." You know what I mean? That's fantastic. But I want to be there for my patients that are experiencing this. I'm recently, just in the last couple weeks, had to send somebody else down to Salt Lake. This is heartbreaking, and they come back and they're just, they're devastated, on so many different levels, emotionally, mentally. But we want to be there for them. These are very uncommon, by the way. I just want to make sure you're aware of that. We have a small practice, but I probably get like 2 a year. Okay. But those are the patients that need us the most, and they need the most support. And, this law really addresses a very, very small percentage of pregnancies. Even those patients where their water breaks before 22 weeks, we're talking just about it's very few. You probably have a couple hundred of each throughout the state of Idaho. But I don't think we should forget about those people. And I think when the people that wrote the law, I think that their goal was to prevent elective abortions, which I don't really want to have anything to do with. I'm here to deliver babies. I have a God to answer to at the end of the day. And, if there's nothing wrong with your baby, I don't really want to participate in that in any way, shape, or form. And most of the OBs in our community are like that as well. But again, for somebody who's in these circumstances, we also can't forget them, and we can't forget what they're going through. And we should be able to offer them options, knowing that their babies are not going to survive, and that they're taking an exorbitant amount of risk by continuing the pregnancy much longer.
Yeah, you bring up a good point that these lawmakers, the intention was to protect the sanctity of life.
Their intention was good, right? Their intention was like, we don't want to kill babies. Well, I just don't think that they understand the full medical circumstances that exist out there, and we're just here to help. You know what I mean? We want to be able to provide them with that information. Hey, these are certain special circumstances that you should look at. We're not asking. And the way it's written too, the way we wrote the legislation, we wanted to prevent anybody from taking advantage of it. So we have a panel of 3 Idaho board certified physicians, a neonatologist, somebody that takes care of really sick babies, an obstetrician, somebody like me that delivers babies, and a maternal fetal medicine specialist that diagnoses these unique circumstances. And they have to be all board certified in the state of Idaho. And they have to agree that this is a true lethal fetal anomaly, that there's nothing that we can offer these poor babies, right? Like there's no medication, there's no surgeries, there's no intervention that we can do to fix this. And it has to be signed by all 3 so that you can't have somebody trying to take advantage of the law. The goal is to really just address these special circumstances.
So to be clear, this is legislation that you've gone out and worked with that says this is how we can address what's not working in the current law?
Yeah. So, I was seeing this happen over and over again, a couple times a year since, the Dobbs decision. And I was like, this just isn't fair to them. We should be able to take care of this without having to call the hospital attorney and review everything with them. And it's happened a couple times where I've had to review things with the hospital attorney, and the conversations are so awkward. Because I don't know anything about legal stuff. I hate legal jargon. And, but anyways, so we shouldn't have to go through that. So I was like, let's do something. So, I wrote something up, and then I went through several different contacts through some of the local legislators here in Idaho Falls. And I was like, hey, can we look at these exceptions? Like, we're not asking to make abortion legal. That is not the goal. It wasn't something that any of us performed here anyways. But we should want to be able to take care of these patients, and we should want to take care of them here, surrounded by their family and their friends and their support structure in these really devastating scenarios. And so I wrote something, and they've made some changes, but essentially that's the essence of what we're proposing, just to make exceptions for those scenarios.
Well, I think it's telling that we talk to a lot of legislators and policymakers, and a lot of times they often refer to their call to the public is come to us with solutions to problems, because we can't know everything. And I have not spoken to a single lawmaker who would understand school facilities as well as you would, who would understand what it's like to deal with non-viable pregnancies as well as both of you would. And I think it's a message to all of our listeners that when you see government isn't working, be prepared to step up and offer a solution. And when my doctor offers me a prescription and I come back and it's not working, they say, let's go back and we either change the prescription or the doses. Let's change things. We love lawmakers who say, let's go back. the law is not working like we intended it to, we want to go back and let's fix it. And I think that's what we want in the people we elect. It's also what we want in the people in our families, people we work with, is to be able to say, okay, that's not working, let's fix it. And it sounds like that's what we're trying to do here.
And I think valuing a different lens, I think sometimes, I mean, I don't know, I would have never, ever have understood how much goes into having to just drive 3 hours to have this done, right? Like, or to deal with that. There was so much a part of that unless you share that story, I don't think people would understand. I mean, just like all the little things, hotel room, babysitter for the whole time you're gone, people you don't know, like I explained before. I just think that lens of here's what it looks like when we have something in place that makes it so that you can't provide what we need here and we have to leave. Here's what it looks like for me now, or for my family, or for this baby. And I think that's important. So.
I think, as Dr. Pam kind of said, in the moment where we should be doing the most, unfortunately, sometimes when government has unintended consequences, you needed more help in those circumstances. Your story is not only heartbreaking and compelling, but like it matters. It needs to be heard.
Right.
And I think it's a great example of where we can improve.
And we also have a ton of resources here in Idaho Falls, right? Like, I mean, we have neonatologists, level 3 NICUs at both of our hospitals. We have pediatric surgeons. You know, our goal always should be, I mean, you know, our patients, they live here, they work here. They don't want to be traveling 3.5 hours somewhere where they have no family and nobody around them, when we have all the resources to be able to provide them with the care that they need here. We have the specialists, we have everything else. I mean, if I was them, I would, you know, be mortified to have to go and stay in hotel rooms in Salt Lake, you know, instead of just be surrounded by family and friends here.
If you think there's one of the biggest misconceptions, I'll ask both of you, surrounding this issue that you could help our listeners and maybe we can clear up, what would be one of the biggest misconceptions surrounding this?
I mean, I think the biggest thing is, you know, a lot of people think any kind of, you know, earlier termination of pregnancy is an abortion. And I think there aren't very many scenarios in which there are exceptions. You know, I've kind of gone through everything that I could go through. And these were the things that were affecting our patients, right? It's really just these two circumstances, you know, knowing that a baby's not going to live after delivery. And I don't blame the lawmakers that wrote the law. I wish they'd have come and hung out with me for 5 minutes. You know, I could have talked to them and been like, hey, listen, I totally know what you're trying to do. I do think that it's the voters of Idaho that should decide whether abortion is legal or not. But let's just take a couple of these medical exceptions that are unique where we know these babies aren't going to survive. And let's just do the right thing for mom. Let's try to really decrease her risks of infection and bleeding and C-sections, and let's do the right thing for mom and at least provide her with some options.
Yeah. Kylie, misconceptions?
I don't know if this would necessarily be a misconception, but I think, again, when the law is put in place, that doesn't mean that these situations just disappear. Like, does that make sense? So, like, the law is there, but then at that point, that's just us handing it over to someone else to help. And I feel like that feels neglectful a little bit of our own. This sounds like really cliche, but like of our own people. Like, I feel like that's one thing that's great about Idaho in general and Idaho Falls and our community. And everybody's really, I don't know, like loving and helpful. And then in a situation like that, it's like, sorry, I actually can't help. And not that that's like what you said, but you know what I mean? Where it just felt kind of like your state just kind of like hands you over to someone else and is like, go let someone else handle the hard part.
You're right. It's not really the Idaho way to say this is somebody else's problem now, especially when people are struggling.
Think that's like the intention behind it. We use this word a lot, like at work, where we say it's like we're not trying to be intentional, or we're not being intentionally like neglectful, right? But it's like, well, we have this law that we're leaning on, so now we can't handle it.
Yeah. Man, so what comes next? For those listening that are heartbroken as I am for a very vulnerable story, who says, okay, well, what can we do to make this better?
Well, hopefully, you know, it'll come to committee, and hopefully they'll realize that, you know, we're not trying to legalize abortion. We're just trying to make exceptions for these two circumstances, essentially, you know, and that's pretty much it. So hopefully the legislators realize that, hey, we should have included this when the law was initially written and confirmed and everything. And, we can go back and we can make exceptions for this so that these poor families don't have to go to another state. And they also don't, the other thing too is this is not an abortion, right? Like these babies aren't going to survive after delivery. And I feel like it stigmatizes those people that are going through it, because they feel like they have to be sent elsewhere because they're doing something wrong. Yeah. And they're not doing anything wrong. They're doing what's right for them. They're doing what's right for their family. I mean, say you did decide you had to, you couldn't leave the state and you were 16 weeks and your membrane's ruptured. These people get sick fast. Once they get infected, that infection can go into their blood. It's called sepsis. And moms used to die a lot from that stuff before antibiotics and modern medicine. So, we have limited time to kind of address these things. And for a baby that's not going to survive because they're not going to have any lung function, we should be able to give these moms options. Hey, you got 4 other little kiddos. Let's give you options. What do you think is best for you?
And then the mother gets to choose.
Gets to choose.
You give the advice as the healthcare provider, and then Kylie
we
gets
know
to decide
that
what's best
baby's
for her
not
family.
going to survive, so you got 2 options here. You can continue on, or you can decide to induce a little sooner.
One of my goals this year was to spend more time talking about things that matter and less time talking about things that don't. And I think this is exactly what this has been. I can't thank you enough for your story. It's raw and real and emotional. And I know we talk about it in terms of, okay, how do we fix this and move on? But I know that that's still heavy for you and still a very real traumatic
I feel
experience.
like going through it, though, it's really easy to pinpoint what you could change, like what we could change to make it better, So.
Yeah, because you've experienced it.
Totally.
Yeah. And Dr. Pam, thank you. Thank you for being here, sharing your expertise and fighting the good fight. We'll encourage all of our listeners and lawmakers to look at the legislation as it starts going through committee, to be able to read it and understand what's going on and then lend their support where needed. Thank you both so much for being on. We appreciate it.
Thanks for having us.
Until next time.